It was in hospitalized patients with lung disease. The endpoint was primarily time to recovery. The result was statistically significant, but really modest. And we must remember, it was only a modest result, showing that the drug made a 31% faster time to recovery. We hope to build on this modest success with combinations of drugs and better drugs. You might recall in this committee that in January of this year, I said that it would take about 1 year to 18 months if we were successful in developing a vaccine. The NIH trial moved very quickly. On January 10th, the sequence was known. On January the 11th, the Vaccine Research Center met to develop a plan. And on the 14th of January, we officially started the vaccine development. 62 days later, we are now in phase 1 clinical trial with the 2 doses already fully enrolled. There will be animal safety. The phase 1 will directly go into phase 2-3 in late spring and early summer. And if we are successful, we hope to know that in the late fall and early winter. There's no guarantee that the vaccine is actually going to be effective. As you well know, because we've discussed this many times in the past, that you can have everything you think that's in place and you don't induce the kind of immune response that turns out to be protective and durably protective. So one, the big unknown is it will be effective. Given the way the body responds to viruses of this type, I'm cautiously optimistic that we will, with one of the candidates, get an efficacy signal. Because this is a virus that induces an immune response that people recover. The overwhelming majority of people recover from this virus. Although there is good morbidity and mortality at a level in certain populations, the very fact that the body is capable of spontaneously clearing the virus tells me that, at least from a conceptual standpoint, we can stimulate the body with a vaccine that would induce a similar response. So although there's no guarantee, I think it's clearly much more likely than not that somewhere within that time frame, we will get a vaccine for this virus.
Thank you, Mr. Chairman.
In fact, in the design of our clinical trials and the sites that we've chosen in our clinical trial network is going to be very representative of being able to get minority populations and populations at most risk to be part of the trial, so that we know during the trial what the relative efficacy as well as potential for adverse events. It's using convalescent plasma in a preventive modality, as well as monoclonal antibodies in a preventive modality, are in fact all feasible and will be pursued in parallel with the development of a vaccine. Neither President Obama nor President Trump are responsible for our not having a vaccine. We moved, as you said, because I described it in my opening statement, rather rapidly. No one has ever gone from knowing what the virus was to a phase 1 trial as fast as we've done. So I don't think that's something that one should say anybody's responsible for doing anything wrong on that. I think that's right. That's the correct way to do it. Is my concern that if some areas, cities, states, or what have you, jump over those various checkpoints and prematurely open up without having the capability of being able to respond effectively and efficiently, my concern is that we will start to see little spikes that might turn into outbreaks. So therefore, I have been being very clear in my message to try to the best extent possible to go by the guidelines, which have been very well thought out and very well delineated. The consequences could be really serious, particularly, and this is something that I think we also should pay attention to, that states, even if they're doing it at an appropriate pace, which many of them are and will, namely a pace that's commensurate with the dynamics of the outbreak, that they have in place already the capability that when there will be cases, there is no doubt, even under the best of circumstances, when you pull back on mitigation, you will see some cases appear. It's the ability and the capability of responding to those cases with good identification, isolation, and contact tracing will determine whether you can continue to go forward as you try to reopen America. But most of us feel that the number of deaths are likely higher than that number because given the situation, particularly in New York City, when they were really strapped with a very serious challenge to their healthcare system, that there may have been people who died at home who did have
Right.
COVID who were not counted as COVID because they never really got to the hospital. So, in direct answer to your question, I think you are correct that the number is likely higher. I don't know exactly what
Right.
percent higher, but almost certainly it's higher. So, my approach towards the possibility of a rebound and a second wave in the fall is that A, it's entirely conceivable and possible that it would happen. But B, I would hope that between now and then, given the capability of doing the testing that you've heard from Admiral Giroir and the ability of us to stock up on personal protective equipment and the workforce that the CDC under Dr. Redfield will be putting forth to be able to identify, isolate, and contact trace. I hope that if we do have the threat of a second wave, we will be able to deal with it very effectively to prevent it from becoming an outbreak, not only worse than now, but much, much less. If we do not respond in an adequate way when the fall comes, given that it is without a doubt that there will be infections that will be in the community, then we run the risk of having a resurgence. I would hope by that point in time, in the fall, that we have more than enough to respond adequately. But if we don't, there will be problems. As I've often said, and I again repeat, you can make a reasonable assumption that it would be protective, but natural history studies over a period of months to years will then tell you definitively if that's the case. That we don't know everything about this virus, and we really better be very careful, particularly when it comes to children, because the more and more we learn, we're seeing things about what this virus can do that we didn't see from the studies in China or in Europe. For example, right now, children presenting with COVID-19 who actually have a very strange inflammatory syndrome, very similar to Kawasaki's syndrome. I think we better be careful if we are not cavalier in thinking that children are completely immune to the deleterious effects. So again, you're right in the numbers that children in general do much, much better than adults and the elderly, and particularly those with underlying conditions. But I am very careful and hopefully humble in knowing that I don't know everything about this disease, and that's why I'm very reserved in making broad predictions. I might point out something that I think has been alluded to throughout some of the questions, that we have a very large country and the dynamics of the outbreak are different in different regions of the country. So I would imagine that situations regarding school will be very different in one region versus another, so that it's not going to be universally or homogeneous. But I don't have a good explanation or solution to the problem of what happens when you close schools and it triggers a cascade of events that could have some circumstances. Containment, if you think that we have it completely under control, we don't. I mean, if you look at the dynamics of the outbreak, we are seeing a diminution of hospitalizations and infections in some places, such as in New York City, which has plateaued and started to come down, New Orleans, but in other parts of the country, we are seeing spikes. So when you look at the dynamics of new cases, even though some are coming down, the curve looks flat with some slight coming down. So I think we're going in the right direction, but the right direction does not mean we have by any means total control of this outbreak. We will have to have infection control capabilities in nursing homes that are really pristine and really unassailable. We'd have to do the kinds of surveillances and have to have the capability of when you identify someone, you get them out of that particular environment so that they don't spread the infection throughout. So general testing for all, I think, is a good start. But when you look where you're going to go in the future, there has to be a considerable degree of surveillance capability. Only testing every person every day, that's one approach that might not be practical when you think of all the nursing homes in the country. But very strict regulations and guidelines about who is allowed to go into the nursing home, and the staff, I believe, needs to be monitored very carefully with intermittent testing to make sure that we don't have introduction into the nursing home of infected individuals. The vulnerables, the elderly, and those with underlying conditions should be those who at the very last lifting of mitigations should be those who are left in a situation where they might be in danger of getting infected. In other words, protect them right up until the very end of the relaxation of your mitigation. Because as you said very correctly, those are the individuals that are the most vulnerable to the morbidity and the mortality. So those are individuals, particularly, I might say, sir, those in the minority group, the African American and Hispanics, who for a variety of situations that are the social determinants of health, have a greater likelihood of not only getting infected, but of also having the underlying conditions that would make their risk for a high degree of morbidity and mortality higher. That if you want to keep things like packing plants open, that you've really got to provide the optimum degree of protection for the workers involved, the ability to allow them to go to work safely, and if and when individuals get infected, to immediately be able to get them out and give them the proper care. But some sort of mask-like facial covering, I think for the time being, should be a very regular part of how we prevent the spread of infection. And there is certainly not a confrontational relationship between me and the president. As I've mentioned many times, I give advice and opinion based on evidence-based scientific information. He hears that, he respects it, he gets opinions from a variety of other people, but in no way, in my experience over the last several months, has there been any confrontational relationship between us.